morning. Thanks for inviting me to this important conference. My name is Gregory Vidal. My talk is entitled Monday Morning Quarterbacking, Breast Cancer. These are my disclosures. So today I was asked to give a basic update in breast cancer, but knowing that my audience is likely nurses and advanced practitioners who have varying exposure to breast cancer, I decided to take the approach of a basic review of management of early breast cancer, and I will sprinkle in pertinent updates where appropriate, and then we'll discuss two recently approved / presented drugs that is going to impact how we treat breast cancer in the future. So early hormone HER2 positive breast cancer. When we see patients who are HER2 positive, we make the decision of whether or not they need to get a less intensive chemotherapy or more intensive. For the less intensive patients, those are usually patients with less than 2 centimeters node negative. They go on to surgery first. We confirm that there are small tumors, and they then get weekly Taxol with Herceptin based on the APT trial that showed there was about a 93% disease-free control at about 9 years. Or TDM1 in the ATTEMPT trial showed it was equivalent to weekly Taxol Herceptin, and then they continue Herceptin to complete 12 months. Patients who are ER positive then go on to have anti-estrogen therapy. If you have bigger tumors, greater than 2 centimeters, lymph node positive, then those patients go on to have chemotherapy in the neoadjuvant setting before surgery, and they get Taxol, carboplatin, Perjeta, Herceptin, or AC, Taxol, or Taxotere, Perjeta, Herceptin, go on to surgery. If after surgery, patients have a pathologic complete response, that is, no more disease is found in the breast after chemotherapy, they complete maintenance Herceptin or Perjeta Herceptin in the adjuvant setting. If those patients have residual disease, meaning that chemotherapy did not kill all of the tumor in the breast, the Catherine trial showed that TDM1 was superior to Herceptin. So TDM1 in the adjuvant or maintenance setting is standard of care. Those patients who are ER positive go on to get anti-estrogen therapy. Neratinib, which is an extended adjuvant, is an option for some patients. Now, patients who had smaller tumors clinically, who after surgery was found to have larger tumors or lymph node, then will go on to get chemotherapy, a more intensive chemotherapy, and then maintenance Perjeta Herceptin. Importantly, follow-up period for breast cancer, every 3 months for 2 years, then 6 months up till 5 years, and then yearly, if not on anti-estrogen therapy. So this is generally HER2 positive. For triple negative breast cancer, most all patients are candidates for neoadjuvant chemotherapy. You can consider upfront surgery for smaller tumors, but most patients are candidate for neoadjuvant. So the smaller tumors, here are the chemotherapy options. They go ahead to get chemotherapy, then had surgery. If they have a pathologic complete response, they get observed following this Q3 months or Q6 months as noted before. But if they have residual disease, the CREATE-X study has shown that addition of capecitabine for 6 to 8 cycles improves disease control for patients. Now, if you have larger tumors, greater than T2 or lymph node positive, those patients should get a higher intensive chemotherapy, which is Taxol, carboplatin, followed by Adriamycin and Cytoxan, starting with pembrolizumab and continuing pembrolizumab in the maintenance setting. This was based on the Keynote 522 study. Now, in the Keynote 522, this enrolled triple negative breast cancers who had T1C, N1 or N2, or T2 to 4 with N0 or T2, good performance status, had tissue for PD-L1 assessment, and they were randomized to chemotherapy plus pembrolizumab versus chemotherapy. Only pembrolizumab was continued in the maintenance setting versus placebo after surgery. Well, the primary endpoint was pathologic complete response. Here we see there was a 13% improvement in pathologic complete response with the addition of pembrolizumab, and that also showed disease control at 3 years, improvement with the addition of pembrolizumab with an improvement of about 8%. That was statistically significant with a very small p-value. Importantly, PD-L1 status didn't matter. Whether or not you were PD-L1 positive or PD-L1 negative, you still got the same benefit. Now, Dr. Laus from Yale presented at ASCO in 2022, looking at the patients who didn't get a PAF-CR, the pathological, via RCB. And RCB is really a measure of how much disease is left after chemotherapy and surgery. So if you had no disease left, which is a pathology complete response, those patients did well. 94 to 92%, even in the placebo arm, had really good control or no disease at 3 years. If you had a little bit of disease found at surgery, which we call an RCB1, your control rate decreased by 10% to about 84%. If you had even more disease, and again, I'm simplifying what RCB is, it's a pathological measurement, and there's an algorithm for it. But if you had even more disease, again, you had a further reduction for the patients who got by 10% who got pembrolizumab, and 20% reduction for the patients who did not get pembrolizumab. So there's a big divide here. And if you had very little disease killed with chemotherapy, your chance of being disease-free at 3 years was only about 30%. So really, pembrolizumab is not the answer for those patients who have residual disease. In terms of adverse events, the most common adverse event was nausea and alopecia, anemia and neutropenia, and you can see it was well balanced between the arm. The lighter colored showed that it was more intense side effects, and we can take a look at the other potential side effects here. In terms of immune-mediated adverse events, infusion reactions was the most common, hypothyroidism, and you can see all of the itis here, but the patients who got pembrolizumab had a higher rate of all of those immune-related toxicities, with hypothyroidism, skin reactions, and infusion reactions being the most common. Now, having had a larger tumor, went on to get the Keynote 522 regimen. Those patients go on to surgery. If you have a pathology complete response, you continue with pembrolizumab. If you have residual disease, we just showed that the patients with residual disease, depending on how much it is, those patients still don't do as well as those who've gotten a PAF-CR. So we think pembrolizumab continued. Capecitabine, as I've said earlier, which has an improvement in disease control for patients with residual disease. I think most breast oncologists will add that to pembrolizumab in that population. And for patients who are BRCA positive, we know olaparib has even better control for those patients based on the Olympia trial. And in the Olympia trial, patients with BRCA 1 or 2 who were hormone receptor positive or hormone receptor negative, stage 2 to 3, sorry, had two groups of patients who got neoadjuvant chemotherapy, and they were triple negative and had a non-PCR or hormone receptor positive with non-PCR and some high-risk features. And in the adjuvant group, triple negative with greater than 2 centimeters or lymph node positive, or hormone receptor positive with greater than 4 lymph nodes, were randomized 1-to-1 to olaparib, which is a PARP inhibitor, versus placebo with invasive disease-free survival as a primary endpoint. On that study, based on the invasive disease-free survival primary endpoint, at 36 months, which is 3 years, there was an 8% improvement of disease control, and that was statistically significant for patients who got olaparib. There was even overall survival benefit at 3 years, about a 4% improvement in overall survival at 3 years, and that again was statistically significant. So showing that if you're BRCA positive and meet the criteria stipulated, olaparib is an option for you in the adjuvant setting. In terms of adverse event, nausea, fatigue, anemia were the most common. We saw headaches, it was almost equally balanced, and there was a little bit more arthralgia seen in the placebo arm versus olaparib. So, so moving on to hormone receptor positive. In the hormone receptor positive, most patients would be candidate for upfront surgery. Patients with T4D, that is inflammatory breast cancer, where the disease is sort of impacting the dermatolymphatics or larger tumors, I would consider neoadjuvant chemotherapy. Those patients should all get chemotherapy. Now, when we see patients with 0 to 1 lymph nodes and relatively smaller tumors, the decision that we're trying to make is whether or not those patients could exclude chemotherapy. And what helps us make that decision is doing genomic profile. Oncotype, Mammoprint, Prosigna are options. Oncotype has the most data, and so we'll discuss the algorithm based on Oncotype. So patient presented, we do an oncotype on this tumor. Patients with greater than 25 recurrent score, whether you pre or postmenopausal, need chemotherapy. Patients with 0 to 25 and postmenopausal, regardless of whether or not you have 1 to 3 lymph node positive or not, they don't appear to benefit from chemotherapy, and they would go on to get anti-estrogen therapy for 5 to 10 years. If you're premenopausal and have lymph node positive, based on our responder data, those patients need chemotherapy. If you have lymph node negative and between 0 to 15 recurrent score, no chemotherapy. The confusion really is in the 16 to 25 patients who have no lymph node and they are premenopausal, whether or not they need chemotherapy. That's currently being studied, but there is data that's showing you can consider chemotherapy based on size, grade, and age. There's a tool called RS Clean that can help you make that decision. So some of those patients may need chemotherapy, and then they can all go on to anti-estrogen therapy. Importantly, and recently approved, is the addition of abemaciclib to anti-estrogen therapy for patients with N1 disease based on the Monarch-E study. In the Monarch-E study, patients with high-risk tumors, hormone receptor positive, in 2 cohorts, cohort 1, high risk, greater than 4 lymph nodes, or 1 to 3 lymph nodes with grade 3 tumors or greater than 5 centimeters, and cohort 2, 1 to 3 lymph nodes, which we call N1, and a Ki-67 of greater than 20%, or greater than or equal to 20%, were randomized to abemaciclib added to endocrine therapy versus endocrine therapy only. In those patients, and again, this may look a little bit confusing, so let us break it down. The patients, this is based on invasive disease-free survival based on Ki-67. So for the patients with high Ki-67, those are the solid lines, low Ki-67, the dotted lines. What you can see is for the high Ki-67, there is an improvement in 3 years for abemaciclib, and here, 79 to 86, 3 years control, and that was statistically significant, versus no abemaciclib. And in the low Ki-67, again, even if those patients do generally better than the patients who had high Ki-67, there also seemed to be a benefit for the addition of abemaciclib from 87.2% 3 years control to 91.7% 3 years control, showing that Ki-67, again, those who have higher did a little bit worse regardless of abemaciclib, is more prognostic rather than predictive of benefit to abemaciclib. However, the FDA only approved abemaciclib for patients who are hormone receptor positive, HER2 negative, node positive with a high Ki-67. And that's probably because we only have about 3 years follow-up. However, ASCO and NCCN recognize that there are patients who meet criteria for the study, meaning that they have lymph node positive and grade 3 or tumor size or a Ki-67, regardless of Ki-67, which may also benefit, and they allow for the use of abemaciclib in those patients as long as they meet criteria for study. In terms of safety, diarrhea was the #1 side effect, and we know that for abemaciclib, that could be in the adjuvant or metastatic setting. Fatigue, neutropenia, importantly, arthralgias were higher in endocrine therapy only, and hot flash were higher in the endocrine therapy only. There were about 4.1% VTE blood clots with the use of tamoxifen and abemaciclib. So pay attention to that if abemaciclib is used with, if tamoxifen is used with abemaciclib. In terms of discontinuation, 30% of patients discontinue, and it was mainly due to adverse events. There was a 61% hold rate and a reduction in about 43% of patients. So in the metastatic breast cancer setting, the only two studies that we'll talk about is the utilizing antibody drug conjugates. There's a lot of talk about trastuzumab deruxtecan or TDXD in the HER2-low space. And just to describe a little bit about these drugs, TDXD is an antibody drug conjugate. The antibody is to HER2, much like trastuzumab. It's a biosimilar of trastuzumab with a payload, which is a topoisomerase inhibitor, and that is linked to the antibody via a linker. This is very important. The linker here is very important because it's not as tightly bound as we've seen with TDM1, which is also an antibody drug conjugate. This is somewhat similar design to another ADC called sacituzumab. Sacituzumab antibody is to a protein called TROP. As far as we know, TROP really has no role in tumorigenesis, but what we do know is there is more TROP expression on metastatic tumors rather than normal cells. So this antibody is used as the target to bring with it this payload, which is also a topoisomerase inhibitor, but a different one. This is using SN38 versus deruxtecan, which is used in TDXD. Similar ratio, 8:1 ratio, and it also has similar what we call bystander effect because the linker is not as tightly bound. What is bystander effect? So in the ADCs, so the antibody gets targeted to the cell based on its target. It brings with it its attached payload or chemotherapy that is internalized into the cell, into lysosomes. The lysosomes break up the antibody from the payload. That payload then is released to go into the nucleus and kill the cells. Importantly, however, that payload can also seep through the pores of those cells and then get absorbed into bystander cells that themselves didn't have the target and also get killed. So that is what we call bystander effect. And that's very important in the efficacy of these two drugs. So the first study we'll talk about is DESTINY-04, which was presented at ASCO, randomized patients with HER2-low. Again, HER2-low is IHC of 1+ or 2+, which are FISH negative, who've gotten 1 or 2 prior lines of chemotherapy. They were in this study, most of the patients were hormone receptor positive, about 60 patients were hormone receptor negative. They were randomized to TDXD versus physician's choice of chemotherapy, and you can see the physician's choice with PFS being the primary endpoint. In this study, in terms of PFS in the hormone receptor positive, there was a 4.7 months improvement in median PFS for the use, I should say, of TDXD versus physician's choice of chemotherapy. And in all patients, that is adding in the triple negative, 4.8 months improvement in the second-line chemotherapy setting. There was also overall survival improvements noted, 6.4 months improvement with TDXD in the hormone receptor positive, and in all patients, 6.6 months. In terms of adverse events, nausea, fatigue, alopecia, vomiting, and neutropenia were the most common. Nausea was higher in the TDXD versus physician's choice. Fatigue was well balanced. Alopecia was slightly higher for TDXD. Neutropenia was higher in the physician's choice of chemotherapy. You can see the other potential side effects here. In terms of side effects of special interest, pneumonitis is associated with TDXD. There was about 6.5%, overall 12% of pneumonitis. Most of it was grade 2. Grade 2 is where patients present with symptoms and needed some intervention. 3 patients died on study due to pneumonitis, so we need to pay particular attention to this. In terms of affecting the heart, there was no difference in terms of ejection fraction decrease or cardiac failure. TROPiCS-02 utilized a very similar patient population, which is hormone receptor positive. There were, again, sacituzumab has been proven in triple negative to be of benefit in the metastatic setting, and that's approved there. This is looking at hormone receptor positive patients in a slightly higher pretreated population. Those patients would have gotten between 2 and 4 lines of chemotherapy, and they were randomized to sacituzumab versus physician's choice, with PFS being the primary endpoint. Here we see, and that was presented at ASCO in June, there was an improvement of about 1.5 months, and that was statistically significant for the addition of sacituzumab versus physician's choice of chemotherapy. And in ESMO last week, they showed that there was also overall survival improvement of about 3 months for patients who had sacituzumab. The Gilead went through and looked at their tumors and broke them down based on HER2 low and HER2 zero, much like TDXD, to see whether or not these drugs also had efficacy in that population. And they were able to show that in the HER2 low, about a 2 months improvement. In the HER2 zero, they also had improvement, which was statistically significant, about 1.5 months. And in all of those patients, again, but statistically significant improvement in progression-free survival, suggesting that sacituzumab also is effective in HER2 low patients. Adverse events, you can see it here: febrile neutropenia, GI symptoms, diarrhea was higher in the sacituzumab arm versus physician's choice of chemotherapy. So in summary, in the HER2 low space, here's how I would use these drugs. TDXD should be priority in the second-line chemotherapy space over sacituzumab. You can consider sacituzumab after TDXD in the third-line space. Again, they both have a topoisomerase inhibitor, but we don't have any evidence that there is cross-resistance. Consider sacituzumab in the HER2 zero space in advance of TDXD, because TDXD is not approved in that space, and in the HER2 unknown. But you should strongly consider path review for all patients lacking or are HER2 zero to see if they are now can be considered HER2 1 plus or HER2 low and could be candidate for TDXD, and should consider rebiopsy for patients who are HER2 zero in order to determine whether or not they are now HER2 low. Thank you very much for your time, and hope you have a fun conference.